I actually was the only principal investigator, not being a nephrologist, I think. The only, so this was a bit. I was involved with the vascular access and with the PD course. So what I wanted to do is just to show a little bit how we organized the course and which topics we actually taught to the residents. And finally, I would, at the end of the presentation, like to give my personal opinion or personal approach that I think we could that we might benefit from future work within the project. So we organized one of the REVAC courses. I think you saw in the previous presentations. This was on vascular access for hemodialysis, and this was in our center, we opted for a 6-day course, which was already quite intense for the residents and also for me, I must say. So on day 1, we started with central venous catheters. We gradually covered several aspects there: an ultrasound evaluation of the central veins, ultrasound guided cannulation practice, and then when these two things were combined in practicing tunneled central venous catheter insertion, and we finally we discussed what to do when there's problems during insertion or when there's complications after insertion of the catheters. So this is just some pictures that we took during the course to give you an example of how we did this. So here, a rapid central vein assessment with ultrasound, which was actually a very nicely published method of standardizing this ultrasound evaluation. We used a chicken breast model of ultrasound-guided vessel cannulation, which is very easy to create. And actually, this has been studied with a real scientific approach to be actually the best model to practice ultrasound-guided cannulation. And this is, of course, useful when the next steps of inserting the catheter are being practiced. So the second day, we took it a step further to creation of arteriovenous vascular access, whereby by discussing how to assess the preoperative, to do the preoperative assessment. So it was on history, physical examination of the patient, and a lot of time we devoted to preoperative ultrasound vessel mapping. And then we combined this information in the case discussion on vascular access creation to decide for particular patients which would be the ideal vascular access, and also to argument why you think that the particular access would be best. So this is the way we practice this duplex ultrasound vessel mapping. And a day later, we would go further by creating the actual arteriovenous access by first teaching how the vascular anastomosis was made. So everybody was creating these vascular anastomoses, and then we went to the and of course a very important surgical knot tying to finish that beautiful anastomosis you created. Then we went to the anatomy department to have a lecture on the surgical anatomy, and finally we ended the day by this beautiful model from Vascular International with flow in the arm, and we could create our first arteriovenous fistulas. The day after, we proceeded, when the vascular access was created, to monitoring and surveillance. Of course, monitoring would be then the physical examination of the vascular access, and we also did a duplex examination of the vascular access. We invited several patients to the vascular laboratory, and so we could have a chance to practice in depth ourselves. Here you can see the physical examination of a patient with an endovascular AV fistula. And we used the duplex ultrasound to examine this further. And then the fifth day, we would proceed to the treatment of complications, and of course, the treatment of stenosis with endovascular techniques. It's so often occurring that it deserved specific attention. So again, we practiced ultrasound-guided cannulation. We taught some guide wire and catheter manipulation skills, and we were discussing how to approach the endovascular treatment of stenosis. And also we did spend some time on the new endovascular techniques to create AV fistulas. So here you can see how we approach this guide wire and catheter manipulation, just to get a feel for different guide wires, different catheters, how you work with these. And you can see here a bit on the cannulation technique, for the ultrasound cannulation technique for the endovascular fistulas. And on the final day, we discussed other vascular access complications together. Finished by exam and, of course, drinks after this pretty long 6-day session. The other course I was involved with was the PD course, which was a little bit shorter, but still it was quite a lot of time to fill on peritoneal dialysis catheter placement. So we started on the first day with, again, doing some basic surgical skills, suturing, tying. Then we proceeded to use these skills in the new simulator that you have already seen to place open PD catheters. And I also thought it would be helpful to get some basic laparoscopy skills, because of course the PD catheters are also inserted a lot by laparoscopic techniques. So here you can see some of these pictures. And we spent the rest of the days visiting surgery, observing surgeries in the operating room, and discussing pre-operative and post-operative management, also of complicated cases, and we discussed the international guidelines together. So this, I think, may give you a broad view of how we approached these, the practical organization of these courses. I think my personal experience with the NPath project is that it really is very helpful in stimulating the integration of clinical practice in Europe. Not only on a personal level, the residents can meet residents from other countries and exchange experiences, but I also think that if this can be taken to another level where more people would be benefiting from these courses, it might, I think, more standardize treatment and adherence to clinical guidelines throughout Europe. And I think that would be a very important point, because it was really an eye-opener for me to see the enormous practice variation in different countries and areas in Europe. I do think that when you want to train interventions, it is very important to not only do this course. I think this course can give you the basics and get a very good foundation for developing these skills, but it needs to be continued by training on the job in the local institution to really get competency in doing these interventions. And I think when you see the practice variation throughout Europe, it is also, in my opinion, could be a very interesting step forward to not only invite nephrologists to these courses, but also to include vascular surgery and interventional radiology residents. Of course, now we have 40 residents that have been traveling throughout Europe for 2 years. When we include more and more residents, it would be very costly and intense for the residents and also for the faculty who will be giving the courses. So I think that it might be interesting to explore the possibilities of implementing these courses in the international meetings that are already out there. For example, here at the VAS meeting, but also at the ERA or the ESVS meetings. It could be so organized that these courses are before or after the meetings, so we can maybe extend the impact of this program in the future years. Thank you.